Hello, everyone, and welcome to our Consult with the Expert. Today, we will discuss key points for managing patients with short bowel syndrome, or SBS, specifically for clinicians who may encounter SBS more often in their practice, such as gastroenterologists with a focus in IBD, colorectal surgeons, GI nutritionists, and GI pharmacists. This series is supported by an educational grant from Takeda. And before we start, please take a moment to answer the pre-polls in the tweets below and let us know who you are. This is a CME certified program, and the tweets below include details regarding how you can obtain your CME credits. I'm Dr. Aline Sharabadi, founder of Monday Night IBD and clinical director of the IBD Center at Johns Hopkins School of Medicine at Sibley Memorial Hospital in Washington, D.C. I'm joined today by my wonderful colleagues, Dr. Valerie Koren and Dr. Simon Gabe. Dr. Valerie Koren is the medical director of the Intestinal Rehabilitation and Transplant at Ann Robert H. Lurie Children's Hospital of Chicago and an associate professor of pediatrics at Northwestern University Feinberg School of Medicine in Chicago. Valerie, welcome.
Thank you.
We are also joined by Dr. Simon Gabe, consultant gastroenterologist and chair of the Intestinal Rehabilitation Unit at St. Mark's National Bowel Hospital in London, UK. Simon, welcome.
Thank you very much. Thank you very much for inviting me. It's good to be here.
Wonderful to be here. I'm very excited by this transatlantic collaboration today. Our disclosures are shown on your screen. In today's discussion, we're going to address a few topics that I think everybody will find helpful and interesting in identifying patients with short bowel syndrome, managing them in their practice, and understanding when it's time to refer them to an intestinal rehab center or program. So the reason we're doing this education activity actually is the fact that even in my practice and talking to other healthcare professionals, including adult IBD specialists, we realize that there's often a lack of experience managing this syndrome, this disease. And actually a recent online survey assessing healthcare utilization of patients with SBS who are receiving parenteral support showed that up to 1/3 of patients felt it was very hard to find an SBS specialist in their area. So what we're going to start with today, Val, maybe you can help us first. What are the clinical symptoms actually that should alert the clinician, seeing a patient in their clinic, that this patient is actually suffering from short bowel syndrome? Are there any tests to confirm? How do we go by with this diagnosis?
When you think about short bowel syndrome, they do differ, the diagnoses, from pediatrics and adults. Adult patients may have conditions such as mesenteric infarction, chronic enteropathies, complications from surgeries, of course, Crohn's disease, for instance, or volvulus or traumas. When we think about pediatric patients, they may be more likely to have necrotizing enterocolitis, gastroschisis, long segment Hirschsprungs. You may also see volvulus atresias, for instance. And so sometimes this diagnosis can be made shortly after surgery. We do know how much intestine a full-term infant has. We know how much an adult has. And so we can use those definitions to also help us. And so sometimes these patients are diagnosed readily after surgery. Other times it may be a later point. These patients may develop diarrhea. They may have signs of malabsorption. Dehydration is frequently occurring, weight loss perhaps. And so these are patients, or these are instances where we need to start considering, is there something else going on with these patients, especially those patients who have inflammatory bowel disease, because we may tend to think this is simply related to their underlying inflammatory bowel disease, but it may be more so related to their surgical complications. These patients may have nutritional deficiencies, whether it's vitamin D, B12, because they're missing part of their distal small bowel. They may require a variety of different vitamins and also minerals to be actually replaced. And so some of the patients may need extra salt supplementation as a result, because they're losing so much salt from perhaps the stoma or perhaps from their diarrhea that they're having. When we think about these patients, you can also do some imaging tests that might be helpful to confirm Again, you may already have the diagnosis based off the initial surgery, but you can do contrast studies, such as upper GIs or CT scans, which may reveal a loss of bowel, for instance, or blood tests that are looking for nutritional deficiencies that can be consistent. Like I mentioned before, B12, different fecal tests looking for malabsorption may be also very, very helpful. You can also look for sodium, looking at sodium levels. Those patients have a lot of output, and sodium is very significant in stomas and also in diarrheal losses. And so that's another common thing where we may actually see hyponatremia in some of these patients.
Thank you, Valerie. So what I understand and what I'm hearing is be mindful of the patient medical and surgical history when you are seeing a patient with diarrhea, malnutrition, malabsorption, electrolyte abnormality, nutrient deficiency. So putting that in context, this one we should start thinking about short bowel syndrome, and maybe additional tests are not key to that. It's mostly the clinical presentation and the clinical history. Simon, anything else to add? I've heard at some point you have to be on parenteral nutrition for a while before you are diagnosed with short bowel syndrome. Is that true? Is that a true concept?
In itself, it's not a true concept, and it is often mentioned. I think it's mentioned more in the States. I'm not entirely sure, but it's certainly not in Europe. But there is a definition, that is, you've got to be on parenteral nutrition for greater than 90 days, and that's a definition for short bowel. Of course it's not. There are lots of conditions that can result in that. A definition of short bowel would be having less than 2 meters of bowel, and the syndrome would be the consequences of having a shortened bowel and a high output, which will be dehydration or nutritional deficiencies, weight loss, all those things, as you've just heard. So it's important that it's not just based on the time of receiving parenteral support. Just worth mentioning.
Thank you, Simon, for that. And I'm going to stay with you. And if you can walk us through what could clinicians, especially those with a focus in inflammatory bowel disease, whether gastroenterologist, surgeon, pharmacist, dietitian, etc., best manage short bowel syndrome locally in their institution, in their practice, with the resources that they have?
The first thing I just want to just re-highlight, knowing the intestinal anatomy, is absolutely crucial, because the recommendations that you will give a patient will be very much dependent upon the anatomy that is left there. So first of all, don't underestimate the importance of knowing how much small bowel there is, what's attached to what. Is it a jejunostomy? Is it an ileostomy? Is the colon in continuity? When you've got that in mind, you then want to give the patient some advice. And if I'm going to sort of break it down, I would start with aspects relating to dietary advice. There's aspects related to fluid advice. They're going to about what they're drinking and what to drink, what not to drink. There'll be aspects relating to medications as a third element. And then there'll be things like the enteral and the parenteral nutrition approaches. Can I just step through those a little bit?
Yes, please.
In terms of dietary advice, it's going to be really dependent upon the anatomy for that patient. If you've got a patient with a jejunostomy or a high output stoma, the dietary advice is going to be high salt, high energy diet, which is going to be low in fiber, and potentially high in fat, which is part of a high energy diet. And if you want, those are the key elements you want to get over to a patient. And a low fiber, high energy, high fat diet, is often all the bad foods that's sitting there, which you're then allowing that patient to have. And it's high salt as well. But if you've got a colon in continuity, it changes. You're allowed more fiber, for example. You still want a high salt diet. You still want to have a high energy diet, but you're going to allow more fiber in this because you've got colon in continuity. And you're going to allow a bit of fat in the diet, depending upon what they can tolerate, because otherwise you'll get a steatorrhea if it's more than they can tolerate. And the final element to this is about oxalate. And patients who've got colon in continuity really do need to go into low oxalate diet, because, and I'm sure people realize, you can get oxalate stones, calcium oxalate stones, renal stones, if you're not on a low oxalate diet. So the other part is about fluid. One of the biggest mistakes that's often mentioned, that patients often hear, is they get conflicting advice as to what to drink. And often they get one set of healthcare professionals saying, drink more. You've got lots coming out. You need to drink more than's coming out. And what that does is it perpetuates a high output. So actually, you've got to drink less. And by drinking less, you lose less fluid and you stay in more balance. And it's a really hard one to understand for patients, but it really needs to be brought over, and it needs to be consistent advice. It's no use if one set of people say don't drink less and someone else says drink more. Obviously, they're going to be confused. We tend to say 1 litre of hypotonic fluid, which is your normal drinks, and 1 litre of an electrolyte mix. And there are various ways of making up an electrolyte mix, but one thing that's worth saying, not a sports drink. A sports drink is not an electrolyte mix. The sodium content and the glucose content is not sufficient. Really important. Medications to decrease secretions, so that's PPIs, are used in reasonably high doses to decrease gastric acid production. And then you've got anti-motility agents, and loperamide and codeine, depending on what you've got available in your country, is what we would be using in reasonably high doses. And then, of course, you've got your GLP analogs, GLP-2 analogs, which are intestinal trophic as well, which will be mentioned later on. So, and then finally, there are aspects related to the parenteral nutrition and the enteral nutrition. I think in the pediatric community, enteral nutrition is used more than in the adult community. But mainly because it's adding complexity. You don't really want to have patients who've got enteral and parenteral support. It's very complicated to manage life. But tube feeding is done, and in the adult world also, distal feeding is being done using bits of bowel that are not getting any forms of nutrition, and that's can be done either by bolus or continuous. And I think there's a bit of debate as to what's better, if it should be bolus or continuous. And then finally, parenteral nutrition is just tailored according to requirements, and you're looking, and that could be that it's fluid and electrolytes for some patients, or it's fluid, electrolytes and nutrition, as in parenteral nutrition, for other patients. And that requires a bit of experience from the team to know what to give when it comes parenterally. I think I might have made that a bit more complicated. I hope not.
No, actually, that was wonderful, because I think I mean, the key point that I'm getting here is absolutely personalize the type of diet to the anatomy of the patient. So thank you for that. And then the second thing in terms of fluid, that was actually very important to know, because I do agree, we often telling patients drink a lot of fluid. So it sounds to me, if I understand correctly, it's like 2 liters, 1 liter of water, 1 liter with electrolyte, not sports drink, but more like the oral rehydration solutions that we have, and to get the right balance of electrolytes. So I think these are actually 2 things that stick in my mind, maybe things I've done wrong in the past. And I think many patients will be excited to know that they can eat salty food and high calorie foods, and it makes sense. It makes absolute sense. So thank you for that. And thank you for this breakdown. And actually, it's fairly reassuring, I think, as a clinician listening to this, as a gastroenterologist without a specialty in SBS, to realize that most of the tools are tools that are available to us in our practice. And we just need to learn how to use them properly. If quickly you can share with us, Simon, what is the dose of anti-diarrhea medication used? That's often a question we get. How high can you go?
It's a really good question that you ask, because there's data, isn't there, now about ECG abnormalities or cardiac abnormalities in patients who get really high doses. And that's based, I think, unfortunately, on patients, drug abusers, who used extremely high doses, 400, 500 milligrams a day of loperamide. The reality is what we are using, generally, I'm using about 8, 10, 12 milligrams QID of loperamide. We do go up to 16 milligrams. I've got the odd patient on 20, 24 milligrams. But realistically, it tends to plateau out a little bit. And going above, let's just say 16 milligrams QID, it really isn't much point. one thing that is worth saying, if you're on these higher doses, I think you should be doing an ECG on the patients, looking at the QT interval. But generally, we're looking at patients on 8 milligrams QID, and I don't think that's necessary. Codeine, we use up to 60 milligrams QID.
Valerie, I want to turn to you and ask you to talk more about Teduglutide. Simon mentioned briefly. I really want to talk about this since it is approved in adult and children with short bowel syndrome. When is it time to start this therapy? How does it work? How does it benefit patients with short bowel syndrome? And how do we give it? How do we monitor therapeutic response or side effects, potential side effects related to this drug?
So, we talk about this new agent, Teduglutide, which is a synthetic analog of GLP-2. It's thought to improve intestinal mucosa with villus height and crypt depth, improving intestinal blood flow, reducing GI motility, and decreased secretion of acid. And the hope is that by its usage, it actually helps with intestinal adaptation. So over time, those patients are requiring less TPN, and a percentage of patients will be able to be successfully tapered from their TPN. When we look at the studies for pediatrics, at least, those patients had to be at least 10 kilograms and at least 1 year of age before they were entered into the study. And that was the minimum. So we did not have any neonatal patients in there, and even any small children. You had to be that weight. They received daily injections of the drug that were sub-Q, usually is given by a caregiver, more than likely a parent who was giving it. The drug seemed to be overall well tolerated. When you look at some of the side effects of the drug, some of the more common were fever and vomiting. What you frequently have to do for these patients is they do have to be monitored closely. You do worry about patients having increased absorption. So if you're giving them a large amount of fluid, these patients are at risk potentially to have edema. So looking for edema on their physical exam. Abdominal pain. These patients may be at risk, especially if you look at them baseline. Did they have gallbladder disease or liver disease? The thought is that it could potentially exacerbate that. So looking for signs of obstruction. Do they have a stoma that's prolapsing more or getting bigger or bigger, getting potentially occluded? So these are some of the main things we look for, and they do require close follow-up. My patients are frequently seen at least weekly for the first week or so, and then you will space them out over time. And I think, educating the family of what you're looking at, and you're asking the same questions. How frequently are they getting it? Are they missing the doses? Do they seem puffy? Do they seem to have a lot of swelling? Do they seem to be having abdominal pain or vomiting? So frequent follow-up with these families is very, very important, because you also worry that they could have increased absorption of certain drugs that may have a narrow therapeutic window. And so definitely trying to monitor that and making sure you're taking that into account. And so then you look at their weight when they come to visit you. Are they gaining weight? And you adjust the dose based off of their weight. It may be every 4 weeks, 8 weeks. You may not have, especially for the pediatric population, because the increase in dose is going to take a lot more weight increase for them in order to actually have an increase in what their actual dosage is as compared to the adult patients.
Thank you, Valerie. These are amazing points. I'm thinking about patients with Crohn's disease who could be on thiopurine, and that we dose based on weight, and then if we're absorbing this drug more, to really make sure that the metabolites are not increasing to a level that could be toxic. So thank you for making that point. Simon, if you can share with us the data of Teduglutide in adults with short bowel syndrome, and any other specific monitoring you do in adults who are on this particular therapy.
Look, I think this is really similar in adults and pediatrics overall. Obviously there's a difference in age, and I mean the age range in the adult studies were from the age 18 upwards. I think one of the key elements in the adults studies was that patients were already adapted. So they'd had at least a year of having short bowel on parenteral nutrition, and that they weren't fluctuating in their requirements for parenteral nutrition. So they were in a stable state. The other element about it is that they've been optimized. And that optimized element means that they're not being given too much IV fluids, IV nutrition. They're not being given too little. Their weight's stable. They're in a steady state. And their medical treatments, that short bowel regime that I mentioned, that has been optimized as much as possible before they start. And then they start this drug. And one thing I'm going to do is I'm going to get really excited. This is a game changer for this patient group. The treatments so far have just been managing this condition, but this is changing this condition. It is absolutely transformative as a therapy. I'm really excited about it, and I'm also really cautious about it. It's not for everybody, but everyone should be considered and offered, I think, for this sort of treatment. Yes, the adult studies show that 20% of patients get off parenteral nutrition support. And obviously higher percentages of patients come down on their parenteral support requirements. And whilst it's measured in terms of parenteral support, actually there's the parenteral support is going down for two really important reasons. One is that their stomal output, if they've got a stoma, has decreased. And that is really important. A high stomal output, leaks, difficulty in quality of life, confidence, all sorts of elements that go with that, has decreased, and they're better. The other bit is they're able to eat and drink more. We've talked about them having a rather, restrictive diet and restrictive fluids, but suddenly this becomes to change, and it transforms their quality of life as a result. Obviously, if they're then getting the line out that they've had, that really transforms for them. They've got no infection risk, etc., thrombosis risk. The liver element is improved. So it's a game changer, this medication. Can I just mention one last bit about Crohn, because you've got to focus on IBD. There is some suggestion or some question as well. What about patients? Is this actually a treatment for Crohn's disease? And look, there are some very, if I can say, poor quality studies that suggest that maybe there's some benefit. Truthfully, the real studies need to be done. But there's a real question as to whether a drug like this could be maybe an adjunctive treatment in patients with Crohn's.
That's fantastic, and thank you both for putting this this data and those numbers in terms of patient perspective and quality of life. Right, getting off TPN or decreasing the requirement of TPN is giving more hours of life to the patient as opposed to focusing on medical care. It's giving them the opportunity to spend more time with their family, with their loved one, go to work, be functional in the society. And I can only imagine how much improvement in emotional, physical, and social health this can give. So I think it's very important to put this data in the context of how much improvement in patient quality of life and being able to have a life. I think that's key. So I could see why you called it a game changer, and I agree with you on that, absolutely. But I think one thing that I kind of gather from both of you and with this conversation is that as you're providing supportive therapy or medical therapy with teduglutide to patients with short bowel syndrome, it really requires a village, right? A multidisciplinary team, which seem to include at minimum a gastroenterologist and a nutritionist, but also likely a social worker, a nurse coordinator, a pharmacist, a psychologist. So knowing that all these components of a multidisciplinary approach is not available to everyone, when is a good time to refer a patient with short bowel syndrome to an intestinal rehabilitation center or program? Simon, can you help us with that?
Yes, I can indeed. I'll be delighted to. I think realistically, if you've got a patient with a short bowel, some patients can get by, and they don't need much in the way of support or any additional support. You can get away maybe with some dietary changes, some medication changes. If you've got, let's say, 2 meters or 2.5 meters left, whatever it is. But the moment you're needing to go up on, the moment you're getting complications, the moment you're getting dehydrated, the moment you're needing really additional support, especially IV fluids, you really should be seen in a specialist center, because no one person can make that person better. It requires all of what you've just described. It requires a physician at the very least, a dietitian more importantly than the physician, and a specialist pharmacist as well. There are specialist nurses who get involved, and obviously when you're considering what you're going to do for a patient, and if they've got bowel that needs to be brought in, you might need to have a surgeon as well. Intestinal rehabilitation centers or intestinal rehab programs, intestinal failure centers, there are lots of names for these, but this is where you get groups of people working together to the benefit of those patients in front of you. And that's when I would suggest that you start to refer patients, is if they're starting to get the complications, they're losing weight, they're getting dehydrated, they're getting frequent leaks, they've got a poor quality of life. You recognize that their bowel is a bit shorter, please refer them on from that perspective. There's one other bit I was going to mention. So with a patient with short bowel syndrome, and one of the key reasons to refer them to an intestinal rehabilitation center or program is to consider what their options are. Is this as good as it gets, or can you do something more for this patient? And the options, I'd say that there are 5 different options. They could carry on as they are with best supportive care. That's home parenteral support and medications and all of that. And actually, I tell you, patients still can hold a good quality of life on home parenteral support when it's done really well and they're monitored well. The other aspect depends on their anatomy. Is it possible to do some form of reconstructive surgery? Is there bowel that's not in continuity that could be brought back into continuity that will make their life better, get them off parenteral support or decrease their requirements? That's number 2. Number 3 will be about bowel lengthening surgery. There are some bowel lengthening procedures that can be done for patients. And obviously you need a program who's used to doing that to know whether this is appropriate for patients. Interestingly, in Europe, those bowel lengthening procedures in adults are really done very infrequently. But I know in the States they're being done a lot more. And in the pediatric population, they're done even more. So it's really worth being referred into a program. You've got the GLP-2 analogues is the number 4. That can be transformative for patients, needs to be prescribed by people who understand the drug. So that's the 4th reason. And the 5th reason is about transplantation. Some patients have a really poor quality of life. They have additional complications, and it just perpetuates. There are no real options for them. And for those patients, transplantation can be considered. There are lots of pros and cons. Sometimes you're exchanging one set of problems for another set of problems for these patients, but sometimes equally by transplanting them, it's transformative as well. So that's why patients need to be referred into a program used to dealing with this condition.
Valerie, you were sharing with me offline how, as a pediatrician, you still have to take care of adult patients with short bowel syndrome because there are very few adult gastroenterologists comfortable taking care of patients with SBS. So my question to you is, how can we create a network or community of healthcare professionals who are supporting each other? Experts supporting healthcare professionals who don't have that expertise in SBS in taking care of patients with SBS.
I think one thing that can be done, it's a longer term solution, is getting the GI fellows excited about nutrition in general. And I think that is something that both we see in the pediatric and the adult population, that nutrition is not as probably viewed as exciting as perhaps endoscopy or transplant, because I think we definitely do need more physicians who feel comfortable managing these patients. I think the program that we're on right now is another way to excite people, to get them interested in taking care of these complex but very rewarding patients. I think using, at least in the United States, we have what's called the Oli Foundation, which provides information for not only families, but also healthcare providers about how to treat and how to take care of patients who have short bowel syndrome. I must admit, living in Chicago, I'm very fortunate. I have at least 3 centers that I can transfer my patients to once they're of age, but I have colleagues that are managing 30 and 40-year-old patients because there are no adults there, adult gastroenterologists or adult physicians who feel comfortable or have a expertise in doing this. So I think trying to, increase the pipeline is one way. I think also working with trainees is another way to also help this. And I think that our national organizations should be also dedicated to this and trying to expose others. And then, you create a circle of network. That patient may not be able to travel to that program. But if you as the physician are finding and develop a relationship with that center, you can serve as an intermediary. Maybe you talk to the person who runs the intestinal rehab program and discuss some of these patient issues. There's a national program that we have, which is actually international, called Lift Echo, that is run out of Mount Sinai with Dr. Keisha Iyer and Joanne Lai. And they monthly, they alternate between pediatrics and adults, and we talk about complex patients and how we take care of these patients. So I think there are a number of resources. It's gonna take time, but I do think using the resources that are out there and developing a relationship with some of these centers would be helpful. That way you'll have somebody to call when you're concerned and you need to potentially refer your patient.
Thank you. That was a wonderful discussion, and I could definitely, you make it more exciting than when my exposure during my fellowship. But definitely you give hope to patients living with short bowel syndrome that there are solutions, there are expert, and there are center and intestinal rehab centers that are available to them, either again directly or maybe through connection between physicians. And I agree with you. The important thing is to keep that conversation going and to have gastroenterologists become more comfortable recognizing and taking care of patients with short bowel syndrome. So I want to thank again my colleagues, Dr. Coran from Chicago and Dr. Gay from London, for joining me today. I want to thank you all for joining us for this conversation. Before you go, please make sure to answer the post-polling questions under the video. Also, don't forget to claim your CME credits. The tutorial, the post-survey, and the credit claim are all under the links in the tweets below or on bonumce.com's website. Thank you again for joining us in this meeting with the clinical experts.